Hello, I hope you all are doing well. My name is Christian Keenan. I am one of the residents at Brown University Health, and today we will be talking about Sentinel events and root cause analysis strategies. As I mentioned, I work at Brown University Health, and for my disclosures, I have absolutely no other sources of financial income or disclosures to note for this presentation, or really anything else for that matter. The learning objectives of today are to understand the definitions of what a sentinel event is, root cause analysis, as well as corrective actions, identifying the steps to performing a root cause analysis, as well as comprehend the various forms of visual representations for root cause analysis. So, to start with, our first learning objective is just basic definitions. A sentinel event is, quote, a patient safety event that results in death, permanent harm, or severe temporary harm. This is actually the definition from the Joint Commission, and it is something that kind of spans anything. And the note is that it can be severe temporary harm, so it can actually be something that is not permanent, thankfully. There are also things under sentinel events that are called near misses. Some organizations use this classification while others may not, but a near miss is exactly what it sounds like. It's actually a safety event that could have caused something severe, but thankfully did not and was caught and mitigated prior to the harm occurring. This is potentially something like the incorrect med was almost given, but thankfully was not. And a root cause, again, this is the definition I believe from the Veterans Affairs, is the fundamental underlying reason why a problem or event occurred. There are many different forms of root cause, and we'll go through how to analyze that, but this will be kind of how to find out what they are. So as we do this presentation is that we're going to do an example case, and the example case will be a septic patient that went into cardiac arrest after many hours in the ED. And thankfully obtained ROSC, because we got to end on a slightly happy note. And just for the basic understanding, the sentinel event that we were talking about is actually the cardiac arrest. Though they obtained ROSC, it is still a sentinel event. It was still a temporary harm. They had no pulse for quite some time. So we will go through the example case with the strategies we are learning through this. So this is a long slide, but this is essentially the general overview of what a sentinel event is. So a sentinel event will happen and there'll be some form of reporting. The reporting mechanism depends on the institution. Some places have these very thorough documentations, others are not as thorough. It all depends on the institution. But the event report will come from somebody directly involved with the event. So in our example case, it may be one of the nurses who was taking care of that patient. It may be the charge nurse. It may be one of the doctors. It's somebody who has some pertinent information, but oftentimes they don't have all of the information. It's very surprising if they do. And what to note is that there will be important pieces of information missing from almost all of the Sentinel event reports. So you need to kind of follow up on that. It's never a complete report. The thing that you want to think about with these event reports, if you are designing the system for Sentinel event reporting or analyzing Sentinel event reports, is you want to understand the full chain of events in the problem. Sometimes it may be something as simple as 2 steps. It may be, oh, the doctor ordered Tylenol, but they have an allergy listed for Tylenol, so they initially ordered it, but we stopped. Sentinel, or that was actually a near miss, and thankfully it's 2 steps. Something may be 20 steps. You'll see in this example, this one will be a little longer simply for the educational purposes. And you'll notice the information you need is kind of the typical who, what, where, why, when, how. But mostly what events happened and what harms happened or almost happened. Another piece of information that is always good to have that likely won't be in the Sentinel event report, but is something to know for your root cause analysis as you go forward with that, is what is the ideal state of how things should flow. Oftentimes these problems occur because of a system failure, and so the goal is to understand what is the ideal system. Is it initially designed for this to be mitigated, or is this actually a flaw that we found in the system that we have to address? Also, part of this is to understand the relevant rules and regulations. How are meds ordered? How are they delivered? What are the regulations on when this med can be given, et cetera, et cetera. The ultimate takeaways of the Sentinel event report are really 2 things. Is this something that needs a root cause analysis, like a full analysis and more information? And is this a problem? Is the Sentinel event something as simple as, oh, the floor was wet after just being mopped and somebody ran through it? Is that something that really is bigger of a problem, or is that something that can be easily addressed without necessarily performing a full root cause analysis? So for our example, this is a little bit of a texty thing, but we'll happily go through it. Our example Sentinel event report is that EK obviously tried to do things as de-identified as possible. 63-year-old, otherwise healthy female who presented to the ED for a fever at exactly 12:03 p.m. Her triage stated that she had a fever for 3 days and came in feeling fatigued. Her initial vitals showed a heart rate of 117, a blood pressure of 88/67, a temperature of 102 degrees Fahrenheit, and a saturation of 98 degrees on room air with a respiratory rate of 24. Obviously, those are not ideal vitals. She was brought back from the waiting room to a hallway without monitoring capabilities in the ED due to boarding at 2:38 p.m. Her assigned attending was Dr. Jones and her nurse was RN Smith. She went into cardiac arrest at 5:08 p.m., received 2 rounds of CPR, was in VFib, and received 1 dose of epinephrine, was defibrillated, and thankfully obtained ROSC. Now she is in the ICU. For the sake of this example, she made a full recovery. So what is a root cause? A root cause analysis, on the general overview, is it's an interdisciplinary method for identifying a flaw in a system in order to create corrective actions that prevent the same problem from reoccurring. The goal is on prevention. It is not on assigning blame. It is not on calling somebody incompetent. It is not for making people feel bad about a mistake. It is about bringing a bunch of people together who have various holds on the problem and identifying what problem in the system exists and correcting it in an integrative manner. The one thing I want to note is this point here is root cause analyses happen quite frequently. They do not mean a lawsuit. These things are not meant to be like punitive. It is never a means to blame other people, and it is never an automatic sign of negligence. So if a root cause analysis is ever done on a problem that you are part of, please do not take it to heart. So the things with the root cause, it's kind of the same thing as your Sentinel event, but your root cause usually goes a little bit deeper. This is the one where you are now analyzing to a much deeper extent. Again, the who, what, where, why, when, how. How severe was the harm? What is the likelihood it happens again? What were the consequences and why did it happen? This last bullet point ends up being the meat and potatoes of the root cause analysis, but these are questions to be asking as you analyze. So this is the map that was created by the Veterans Affairs Department. They're actually the people who really brought about root cause analysis in a structured manner, and a lot of healthcare modeled their root cause analysis strategies over the VA. So this is the map that they actually created. It's slightly altered, but not by much. They created essentially 4 steps. The setup step, where you essentially get your team ready to perform the analysis. So establish your team and identify your initial problem. The analysis step, this is essentially the big step where you want to get all the information, you want to investigate the safety of the situation, and you want to understand, is this a trend or is this a one-off experience? Oftentimes, if you're performing root cause analysis, they are trends, but we will come back to that. Plan and feedback. Obviously, coming up with why did this happen is great. However, you want to make sure it doesn't happen again. So you have to create a plan for how are we going to address this. And before you create your plan, or before you enroll or enact your plan, you want to establish the metrics, because you don't want to be creating metrics as you do it, because that creates a flawed evaluation of your intervention. And then implementation and measurement. So measure the impact of your corrective actions, and you either have to say, wow, we did great, let's sustain this, or, oh, we didn't meet our goal, so now let's repeat it. So the setup step, again, this is before performing your analysis. You need to define your problem. This is always something that really is the make or break part of it, because sometimes it can set your tone in a different direction. So the problem is the ultimate harm, the identified quality waste. There are many, Lean Six Sigma has many different forms of waste. Obviously, cardiac arrest in our example is very much a waste. It's very much a harm that could have been prevented. But there are other things like wait times and overanalysis that you can see on various sources. And then what is the bottom line of the Sentinel event? We read that Sentinel event report, and it was essentially that the patient went into cardiac arrest. There's a lot of information that led to that, but the ultimate thing was the cardiac arrest. The one thing I will say is when you're identifying a problem is people will say to create a problem statement. My background's in engineering, and that was the one thing we spent a whole host of time on. But the identified problem is not the absence of a specific solution. Sometimes people will phrase a problem and say, oh, a patient didn't receive their home insulin. And so you're suggesting that their home insulin is the only solution. However, the example of the problem could be a patient did not have adequate hyperglycemic control. They may not receive their insulin regimen at home. They may receive some modification, but with good resolution of their hypoglycemia. So it's not exactly their insulin regimen, but it is a form of hyperglycemic control. So phrasing your problem allows you to kind of expand what the solutions can be. And as you progress through your root cause analysis, sometimes you may notice that you may need to change the problem. You may need to change the definitions. You may need to change what your ultimate bottom line is, and that is A-okay. So for our case, the problem that I'd put it is a septic patient with no medical history experienced a cardiac arrest while in the ED. Short, sweet, to the point. And as we go through this, we may change it. So analysis step, this is again the 5 whys, or the many questions. I purposely put this picture at the bottom because you want to kind of act like a child, the typical 5-year-old who always is asking like every adult around them, why? There's actually a thing that they always call the 5 whys, which I used to think was 5 things that started with why, but is actually asking why at least 5 times. You want to obtain the full sequence of events. So oftentimes a Sentinel event report will include at least just parts that the reporter knows. Oh, I was the doctor and I just know that this patient was put in a hallway bed and then they went to cardiac arrest 2 hours later. I may not know what's going on in their triage, what brought them in, who brought them in, why did they come in. And so you want to get as much of a panoramic view of events as you can. You want to see how all the factors like interplay, because oftentimes these are never just one thing went wrong. It's usually there's a flaw in a system here and a flaw over there, and you kind of have to see how the system various facets interplay with one another. You often interview people involved and say, and again, in a non-judgmental way, I want to obtain more information and figure out why did this happen. And again, you want to identify how things are supposed to ideally work and then what happened. And you'll see how we want to compare those two things. And again, this is the most important part. Is this a trend? Oftentimes when you're doing this analysis, you'll find out, oh my God, this is for our example, this is the 4th person who went to cardiac arrest in the ED from the waiting room. This is now a trend, as opposed to, oh, this is one time. Could this become a trend? That is a very good question. But you want to kind of understand, is this very much an existing systemic issue, or is this a possible soon-to-be systemic issue? Both are good questions to ask because it affects how you address the system as a whole. And so as you want to obtain an understanding of the flow of events, you want to understand the full panoramic view of it. So oftentimes getting a giant block of text is not visually appealing, and it kind of helps, or it hurts the understanding of the system or the situation that happened. So what people do oftentimes is they do a flow of the events, which helps everybody kind of understand what's going on. So in our example, our patient checked in at 12:03. They got triage 4 minutes later, which is great. They got an EKG. All of this happened within about 10 minutes. But then they were brought to a hallway bed after about 2.5 hours. They were assigned a nurse, and they just placed an IV, and Dr. Jones signed up for the patient, sees the patient, and orders blood work, and then 5:08, that's when the patient goes into VFib cardiac arrest. So it kind of helps you understand this was a 2.5 hour-ish delay. They were seen about 9 minutes later, but then doctor sees them about 20 minutes later. Blood work is ordered 20 minutes after that. And then there's this 1.5-hour gap right here. So it kind of helps you understand like what happened, but it also helps you think, what did happen in this 2.5 hours? What happened in this 1.5 hours? And allows you to create a bigger diagram as you go through. So one thing we talked about was, how do you understand like where the system is? You have to understand where the ideal state is. So this is just one of those things. Obviously, I'm making this up. This is obviously a made up example, but the ideal flow is something you want to compare the real flow to. So we have the real flow of events as they occurred, but now we want to sit there and say, how did this deviate? Did this deviate at all? So oftentimes you'll sit there and understand the rules and regulations that bring you there. And so you'll sit there and say, maybe this is the ideal flow of a septic patient in triage. And so we could sit there and say, oh, here was this hospital's like ideal flow. Here's their ideal flow for delivering antibiotics. You can create an ideal state for bringing the patient to x-ray, for the doctor signing up for them, for whatever it is. But having those so you can easily compare and contrast is extraordinarily helpful. And then the ultimate thing that all QI people love is what's called the fishbone diagram. The more formal term is called the cause and effect diagram. And essentially what will happen is that you'll be focused on, it looks like a fishbone, I guess, but essentially what happens is this is the ultimate problem. This is your problem statement that we created. So our septic patient without a medical history went into cardiac arrest. That will be our problem right here on this side. And then you create categories because it helps you to kind of compartmentalize exactly what you're worried about. So these categories often can be something like personnel, environment, barriers, and we'll go through that in the next slide. And then let's say it's personnel. Oh, there was only one triage nurse when there's usually 6. There was only one resident when there's usually 5. That could be personnel. Or environment. The ED was extraordinarily boarded. That is going to be a universal experience across the nation, unfortunately, at this time. But that could be something that interplays. Technology could be, oh, the monitor that was supposed to be assigned to that room wasn't working, and that's why the hallway bed was there. But all these categories kind of go from there. So these are the common ones that are often seen. I see this more times than not. But essentially, what you'll see is communication. How was this communicated? How was it not communicated? Where it was something sent and somebody ignored it, or was something never sent? Equipment, that's often the technology. Environment, boarding is almost always on this one when it comes to the emergency department, unfortunately. Policies and procedures. This is actually a very common one that the VA creates, is fatigue and scheduling. That was one of the ones that they recommended in their very large PowerPoint that they have, which I thought was very interesting. I've not seen that one as readily. And then barriers, which could be much more of a broad category. So in our root cause, I created this based off of just ideas. Let's say this is essentially what happened. Oh, sepsis was not documented. Oh, messages in the EMR were not read. There were no IV pumps, so this patient who was ordered for antibiotics never could get them at the proper rate. They were never ordered for antibiotics, so maybe it was one of those. So they never got their fluids in a pressured way. The nurse had 5 critically ill patients. Again, the environment is very much the things outside of one individual person's control. So maybe this was one of 5 septic patients that this nurse had, and they were only one human trying to do the wonderful job that they do for 5 critically ill patients, which is just extraordinarily unfair for that nurse. The entire ED is boarded, so therefore everybody is admitted, and there's very few active beds to work with. These are all just examples of what could happen, and you'll notice this graph is very much populated with various ideas that are various things that could go wrong. This seems like the perfect storm of somehow sepsis was not documented, EMR downtime, the IV infiltrated, the entire ED is boarded, but an emergency mess, and it seems like every day is a catastrophe. So you'll notice the root cause analysis, the fishbone diagram, should not be just one category filled in, it should be many. And so after you do your analysis, you sit there and say, okay, we have our causes, and we created this root cause analysis. Again, is this a trend or a one-time thing? Oftentimes when you sit there and say oh, the IV infiltrated, is that a trend? Nah, maybe not. But boarding, is that a trend? Absolutely. And so some of your causes will be trends, some of them may not. And it allows you to kind of understand which ones can we address and which ones can we not. So what you'll do is, I'm going to go back to the previous slide, you'll say, for example, never order for antibiotics. That is, let's say that's a trend. That's something we can address, as opposed to EMR downtime. Maybe it was scheduled downtime. I don't know. But is that something we can readily address? Maybe not as much. It depends on kind of the size of your scope and who is involved in terms of your stakeholders. But you'll sit there and say oh, some of these we can address easily, some of them not so much. So then what you do is you say, okay, you know what? Let's address never order for antibiotics, or let's address never order for antibiotics and the nurse having multiple patients and the provider called out and backup hadn't arrived. Let's say all of that stuff happened. You could create a multifaceted approach. You could create one-sided approach. It is up to you and kind of what your team decides. But what you'll do is you'll sit there and say, here are our gaps. So you want to say, how are we deficient? And so you could sit there and say, you want to create a benchmark. You want to say, hey, patients should be ordered for antibiotics within 10 minutes every time, based off of some national benchmark or some institutional goal, whatever it may be. But you want to create a numeric goal. And then what you do is you say, okay, where are we at now? So you get some numbers. That always helps sell the circumstance and the interventions when you sit there and say, hey, we're supposed to be at this point, but we're very much not. And we're 20% off, 40% off, 100% off. And it helps you understand the scope of the problem when you use numbers. And then what you'll do is you say, you know what, let's identify goals. Sometimes you'll say, oh, we have this national benchmark that says, for example, based off benchmarks, patients should have antibiotics ordered and delivered within 3 hours. That's something based off the SEP 1 bundle. But let's say your goal is like, you know what, we are very far off from 3 hours. Let's aim for 4 hours when we're at 4 hours and 37 minutes. You could sit there and say, you know what, our goal needs to be 3 hours. Your team will decide based off of rules and regulations and the institutional goals. But you want to assess how will it be measured. Oftentimes the goal, like the metric that you're using against, is exactly the same units that you're going to use to like address your goal. You wouldn't say, oh, we need to wait 3 hours, or we need to have this in 3 hours, and then you want to measure some sort of percentage on how often that happens. You want to measure what the average time is. So measure apples to apples and oranges to oranges, no apples and oranges. So then what will happen is you'll create your plan and you'll have some sort of intervention. There are various forms of corrective actions. And so you'll sit there and decide what are your addressable one or multiple multiple causes that you want to address. And you'll develop a plan for each of them. What happens is that there's different forms of interventions, and not all of them have the same impact in terms of quality improvement. The most effective system-focused one is what's called a forcing function. And so the definition of a forcing function here is a built-in required step in a process that ensures a specific goal is met before the next step can start. A very massive one is when you're going to turn on a car, you can't turn on without somebody pressing on the brake. Like your car will not turn on no matter what. That is a forced function. Other ones are another more medically aligned one is oftentimes when you order antibiotics or any sort of medication to be given to a patient, you first have to agree that they have no allergies or review their allergies and acknowledge that's the case before any sort of intervention can be ordered for the patient. That is a forced function. There is no way around it. Those are usually the most important ones, but those can be very hard to design. So then you'll see some of these other ones. Usually the ones that are less difficult to design are also ones that are more readily available. So education and training, less effective, but easier to do in a long-term goal or like in an easy way to intervene. And so there's various levels in terms of like intervention success versus readily available. So then you create your plan and feedback. And this is again based off of our example. So we would say like, oh, in the Sentinel event, antibiotics were ordered during the code, but not before. So it was after 5 hours and 12 minutes. But our standard says that it should be within 3 hours. Again, I'm just creating the SEP 1 bundle. And then we come to find out, hey, this is actually a trend. And get this, we're at an average in our hospital for 4 hours and 37 minutes. Again, this is a fictional hospital. I am not speaking on behalf of any hospital I've ever worked in. But now we sit there and say, you know what? Now we have a goal. Our goal before we create our corrective action is to have the average time of administration of antibiotics. Let's be at that national standard. Let's be at the SEP 1 bundle, especially because it's like highly regulated. Some other standards may not be as heavily regulated, so you may go for, again, a lesser goal. But we're going straight to the top. We're going for that 3 hours. And again, we're going to measure the average time from first triage vitals, meaning severe sepsis criteria, to administration of antibiotics seen in the MAR. And you want to say, like, especially when you measure time differences, you want to measure what is the endpoints, the start and the stop time to measure the elapsed time. And our new intervention, we're going to actually have a bunch of them. We're going to create a new code sepsis protocol. We're going to have nurse on standby for code sepsis. We're going to create a force function and all these other interventions. So again, you may have one root cause, but you can have multiple interventions. 3 interventions for one thing is awesome. And then what you do at the end is you say, hey, you know what? How do we do? So after you intervene and you create your intervention, you want to measure, did we work? And so this is the most very straightforward thing. You measure your predefined metric. So our time that we want to have from triage vitals to antibiotics delivered. Let's say we wanted to aim for 3 hours. We got 2 hours and 58 minutes, just squeaked it by. Now we did a great job. Let's focus on sustaining it and making sure that never happens again. So sometimes that means prolonged education. That sometimes means keeping the forcing function despite if people are annoyed by it, or sitting there and making sure that staffing is staying there. Versus, let's say we were aiming for that 3 hours and we had 3 hours and 30 minutes. We did a good job, but we didn't hit it. So you can kind of do a bunch of different things. You can either say, you know what, is the 3 hours and 30 minutes, missing it by that much, is that fine? Or can we redefine the goal and say, you know what, we're fine with 3 hours and 30 minutes. That's usually something that is not readily done, oftentimes because you are already saying this is the goal of our institution, so changing your goal is not as readily done. Consider repeating your RCA. Were there root causes that you missed? Are there other interventions you can create? Or let's keep the interventions, but let's change them up a bit. So, and then what happens is you do this step and then you repeat the process. Did we meet the goal? And it's an iterative process, as we already mentioned. So that is essentially root cause analysis on an overview. I hope this was very helpful for you. If there are any questions, concerns, feel free to reach out to me. This is my personal email. I hope you enjoyed this. I hope you learned something. And I hope you all have a good rest of your day. Thank you all. And here are my sources. Have a good one. Thank you all. Goodbye.